I'm one of the founding partners of Frier, Levitt, and I hope you've all been staying healthy during this very strange time that we're living in. And what I'm finding is that there's certain topics in healthcare law that are becoming more and more popular for whatever reason. One of those topics is the concept of a captive practice, otherwise known as a friendly practice. So what in the world is a captive or friendly practice? Okay, a captive or friendly practice is a medical practice that is owned by physicians, but is controlled, usually, or at least whole or in part, by a separate company, either a hospital or a management services organization, or as a group of investors that can't legally own a medical practice but want to gain some financial benefit from being associated with a medical practice. So why would someone ever want to form something like this? Why not just own a medical practice? Why would you want to form an entity that has a contract with a medical practice? And the answer is that in most states, almost every state, medical practices have to be owned by licensed physicians. They cannot be owned by business people. Bill Gates could not own a medical practice, as smart as he is, as much money as he is. He cannot own a medical practice. He can own something that does business with a medical practice, but he can't own the actual practice. So today we're going to talk about three basic models. As I was trying to prepare for this, I was thinking, what are the basic models of a captive practice? And I think they can be distilled into three areas. One is a hospital captive, right over here. We're going to talk about each one of these individually. The second is a private equity-based captive, which is in the middle. And then the third is what I'll call a startup captive, for lack of a better term. So we're going to talk about each of these three items, each of these three models, and how kind of they impact the practice of medicine and why they're utilized, and hopefully you'll get some information that's useful for you. So starting with a hospital captive. One of the really interesting things about hospital captive practices is that most people don't even realize that they exist. When you think of a hospital practice, you think the hospital owns the practice. It's a hospital practice. But in reality, in many, many states, not all, but in many states, even a hospital cannot own a medical practice. It cannot own it directly. So in fact, the hospital doesn't own the practice. The hospital either manages the practice or it owns a separate company called a management services organization, which provides services to the practice. So if you look at this diagram over here, you have a hospital and you have the captive practice, which is, in some cases, thousands of doctors could be employed by that captive practice. So how does the hospital associate with this captive practice? When I do dotted line, that means a contract versus an ownership model. So it's usually in the form of a contractual relationship with the captive practice. So who owns the captive practice in a hospital model? You'd be surprised to know that most captive practices are owned by a hospital-employed physician, like the vice president of medical affairs or some medical director. An individual who has an employment contract with the hospital that often says, hey, while you're employed by us, you're going to own this captive practice. But if we ever have a falling out and our relationship ends, you have to terminate your relationship, you have to resign, and we can replace you with the next person. So what's happening is the hospital really almost has like a puppet, for lack of a better term, who owns the captive practice. And if you deal with the captive practice, you may never run into this absentee owner. But that's the person who actually owns the practice. And then the hospital just provides services to that practice. I could do an entire series, and I probably will, just on this relationship and some of the strange things that result from this relationship. But it's probably beyond the scope of today's discussion. We're going to get into other types with a little more detail today. So the second type, which some of you have heard of, is a private equity-based MSO. So unless you're completely new to this concept of healthcare and the business of healthcare, you've probably heard that private equity is very, very interested in relationships with medical practices, largely because most medical practices are small, somewhat inefficient, and they're in a fragmented marketplace, meaning there's many, many, many providers, none of them are interconnected, and it's like having a ton of different hardware stores. Home Depot came in, consolidated hardware stores, and made it difficult for the individual smaller hardware stores. That's what private equity is doing in different specialty practices. So the way private equity does it is the private equity company will come in and form a management services organization. Now, what is a management services organization? It is an entity, usually it could be an LLC, it can be a corporation, it can be formed anywhere in the country, typically, very often it's formed in Delaware or another state that's favorable to corporations in this country. And the MSO, by definition, performs certain non-clinical functions for the practice. So what are non-clinical functions? Non-clinical functions could be billing and collection. That's the most simple non-clinical function. So in a sense, every single medical billing company is really nothing more than an MSO that provides a single service, medical billing. Okay, it could also provide IT services. It could provide human resources, marketing. It could provide accounts payable, credentialing with payers, payer relationships, payer contracting. It could own all of the equipment of the practice. It could employ all the non-clinical staff of the practice. The MSO, remember, cannot employ physicians. In most states, it cannot employ nurse practitioners or physician assistants or other clinical providers, but it can employ receptionists, billers, patient liaisons, other employees that aren't actually providers of a clinical service. It could rent all the space. All of the medical practice offices could be essentially rented or owned by the MSO and then leased over to the practice. When a private equity group buys a medical practice, what they're really doing is they're not buying a medical practice. They're forming a management services organization which buys the non-clinical assets of the captive practice. All those things that I just mentioned are being purchased by the MSO. And what's left in the captive practice is typically only the clinical assets, which in private equity parlance really means the doctors, the non-physician healthcare providers, and the name of the practice. That's basically it. Everything else is being purchased by the MSO. So effectively, there's nothing left in this entity except the doctors, basically. So this is also just a contractual relationship. And often in this situation, some of the doctors remain owners, many of them become employees, and maybe there's one or two owners left in the captive practice in many situations. But at the end of the day, the doctors own the practice, but they are under a long-term management agreement with the private equity group. This solidifies the private equity group's investment in the practice, in the MSO, by having this long-term management agreement. So another typical use of a captive, and we see this a lot, and I've seen this for years, is I'll call it a startup captive. What that simply means is you have a business person who wants to get involved in the business of healthcare, the business of medicine, but they can't own the practice, so they create a captive relationship. I've seen this with medi-spas, so you might have, for example, business people that own a management services organization that manages a medi-spa. The medi-spa itself, a lot of people don't realize this, but it requires that you have a license to practice medicine to own a medi-spa. So the medi-spa has to be owned by a physician. And where the term friendly physician came in is in this startup captive model. Because often what happens is the business folks who have the money, they have this business model, they've done a business plan, they have several $1 million ready to invest. They need to find a physician who can own the actual clinics. And so they need to find a physician in each of the states that has a license in each of those states who can own these clinics, but not have a significant amount of control. So they find a physician, sometimes it's a family member, sometimes it's just a doctor that they've worked with or they trust, or sometimes it's a doctor they don't know at all, but they have a relationship with that doctor. Possibly the doctor may have an ownership in the MSO to kind of solidify the doctor's relationship, give the doctor skin in the game. And the doctor is the owner of the captive practice, and the captive practice, like model number 2, has a long-term management contract with the MSO to provide services. And what's really interesting about all three of these relationships is that at the end of the day, the captive practice is the client, and the MSO or the hospital is the service provider. It's a vendor. And that's the part of this relationship that many people overlook. The captive practice doesn't work for the MSO. It's the opposite. The MSO works for the captive practice. It's just that it seems that it's the opposite. It's designed so that financially it's the opposite. And this is where people can get into trouble, and I'll finish on this note. Captive practices pose a number of regulatory risks that business people often overlook. Even attorneys who do this often take for granted. And that involves the following areas. Number 1, the corporate practice of medicine. The reason this entire captive practice model even is in existence is because most states have a corporate practice of medicine prohibition, meaning you can't own a medical practice through a general business corporation, and you can't own a medical practice unless you're a physician, because they don't want non-physicians controlling the practice. And so if you set up this captive practice model so that basically the MSO or the business people have all of the control, you can run into trouble with corporate practice medicine. And that not only impacts the physician's licenses who are involved, but it also can result in a False Claims Act case, an insurance fraud case, because in an improperly formed captive practice model, whether it's any of these three, if the captive practice is billing Medicare or private insurance companies in a situation where it is set up in violation of state corporate practice of medicine laws, every one of those claims is a false claim, potentially. And every one of those claims is subject to recoupment, damages, potentially even criminal violations, depending on the situation. So corporate practice of medicine is a big issue. The second big issue is anti-kickback. Okay, where you have, and this happens mostly in the startup captives, where you have an MSO that among the other various management services is providing marketing services. And this happens very often. The MSO is providing marketing services to get patients over the captive practice. In that situation, if the captive practice pays an amount over the MSO that's inappropriate, that could be considered a kickback. We have seen many situations in my practice over the last 20 years where something looked like it was just a legitimate MSO relationship with the captive practice, but in fact, it was really a patient referral service, where the MSO is approaching my client, offering them a stream of patients and asking to receive a piece of that stream of patients, which is effectively a kickback. And the third thing, which is closely related to kickbacks, are state fee splitting laws. Many states have fee splitting prohibitions, like New York, for example, that prohibit physicians from sharing their fees with non-physicians. Both parties can be in serious trouble if they do that. And the last thing I'll mention is complying with regulatory requirements, whether it be federal or state laws, basically comes down to one important thing, and that is, what is the management fee? What is the amount that the captive practice is paying the MSO? Ideally, the MSO wants the practice to pay all of its profits over the MSO, leaving only that which is necessary to pay the physicians behind. And that may be the net effect of the management fee, but it can't be the actual purpose of the management fee. Because if it does that, it risks kickback problems, it risks corporate practice medicine problems. So the management fee has to be reasonable. It generally has to be fair market value. In some cases, it can be percentage in some states. In some cases, it cannot. In some cases, it has to be a flat fee. In some cases, it can be what's called a cost plus fee, where the MSO is charging a fee that equals the MSO's out-of-pocket costs for supplying all the management services, plus, let's say, a percentage of those costs. 10 or 20% is a typical number. When we do these deals, we almost always recommend that the parties obtain a valuation from an outside, nationally recognized valuation firm to determine fair market value, so that nobody is left, essentially with a situation that, unbeknownst to them, is really effectively a kickback. Anyway, thank you so much. I hope this was helpful, and we'll be back soon, hopefully with another lecture series. Take care.